Welcome to Module 2. Here I will review Appendices A, B, and C of the Nova Scotia Standards of Practice for Non-Sterile Compounding. Upon completion of this module, you will be able to define compounding, determine when it is appropriate to compound, describe the different roles and responsibilities when it comes to compounding, and in particular, the compounding supervisor, and also explain the training required to participate in compounding activities. It's important to understand what is considered compounding so we know when to apply the standards of practice. Compounding is defined as combining two or more products, one of which must be a drug, into a single preparation. Products that are altered before dispensing, in accordance with their directions for use, are not considered compounds. Examples of these would be reconstituting antibiotics or mixing up a product like clindamycin benzoyl peroxide gel. Before deciding to make a compound, you have to consider if it is necessary and appropriate to do so. Pharmacy practitioners must only prepare a compound when there is a valid prescription, when they have the required equipment and facilities, and when there is appropriately trained staff. There must also be a therapeutic reason to support the compounding. For example, when there's no commercially available product, or when a commercially available product is not appropriate due to formulation or dosing. It's also important to consider if there are any acceptable therapeutic alternatives that would not require compounding. Consider a prescription for Prevacid suspension where the dose is 15 milligrams. This 15 milligram dose is available in the fast tab formulation, and there would be no need to compound it. So you have to consider if the fast tabs would be an appropriate alternative to the compounded suspension. The answer would likely depend on the age of the patient, and a conversation would be necessary to determine which formulation would be best. We also need to determine if there is an available formula. If there is no published or established formula available, is there a reasonable body of evidence to support the creation or use of a formulation? If you've never made the compound before and you can't find a formula, can you still make the compound? The answer is maybe. You're probably going to need to do some research to determine if what is written on the prescription is even plausible, and then you should be having a conversation with both the patient and the prescriber to discuss the lack of evidence and also determine the need and get informed consent from the patient. Let's look at an example. If you were to receive a prescription for topical valacyclovir to treat cold sores, would you crush up some tablets and make it? Well, valacyclovir is a prodrug and needs to get converted to acyclovir through first-pass metabolism. So topical valacyclovir doesn't really make sense. How about a prescription for 8% nifedipine ointment to treat scleroderma? We know that oral nifedipine can be used for things like Raynaud's, and we know that topical nifedipine can help reduce local ischemia. So in this case, we are starting from a place that makes sense. If we can't find an established formula, can we find one that is similar? This is where a discussion with the patient should take place so that they can make an informed decision about the risks and benefits and extent of evidence. The point here is that you just can't go ahead and make a compound because a prescriber wrote it on a piece of paper. But it also doesn't mean that every never made before compound is excluded from use. There are also formulas that pharmacists have been making forever, and Appendix E specifically says, historically, pharmacy practitioners have prepared many CNSPs in accordance with recipes or formulas where the rationale for their use is based upon long-term use and tradition rather than robust clinical evidence or published literature. Think of our magic mouthwashes. These standards do not preclude the continued use of these formulations. However, their use must be based on a consideration of the appropriateness of their preparation as described within the standards. All pharmacy employees who are involved in compounding need to understand their role and responsibility. The pharmacy manager assumes overall accountability of compounding in the pharmacy, but they can delegate responsibility to a compounding supervisor. This would be the go-to person for anything related to compounding. The compounding supervisor has to be a pharmacist or pharmacy technician. A pharmacy assistant cannot be assigned this role, as it must be a regulated professional. The compounding supervisor is responsible for the development, implementation, and oversight of the pharmacy's compounding services. The pharmacist on duty is responsible for ensuring that during their shift, the standards are being followed and that staff performing compounding duties are given appropriate direction and supervision. As previously mentioned, the compounding supervisor is a pharmacist or pharmacy technician who is responsible for developing and implementing compounding services. They oversee all aspects of compounding in the pharmacy. Appendix B of the Standards of Practice lists the responsibilities expected of the compounding supervisor. Verifying that staff are trained to ensure those who participate in compounding are competent to do so, and that they have read, understand, and follow the standards of practice. They develop and enforce policies and procedures for all compounding activity and equipment. They ensure safety data sheets are readily accessible for each active pharmaceutical ingredient. And for each compound, they must complete an evaluation of the compounding practice and environment, and also ensure a master formulation record, or MFR, is created and kept up to date. They also need to make sure compounding is included as part of the pharmacy's overall quality assurance program. The quality assurance program must include a process for reporting incidents and responding to recalls related to compounding. Does the pharmacy where you currently work have a standard procedure in place to investigate when a patient brings a compound back to the pharmacy that looks different or has a different smell or taste compared to the last time they picked up that compound? My guess would be that in most pharmacies, the answer is no, and the response to the patient would vary depending on which staff is working that day. All staff need to be trained to respond to potential errors and recalls effectively to avoid ongoing patient safety issues. Last but not least, all of these things must be documented, and there must be a system in place to ensure that these documents are readily retrievable. The compounding supervisor must be satisfied that all staff members taking part in any of the processes involved with compounding are appropriately trained. This includes those who prepare compounds, verify compounds, and clean the compounding area. Not all pharmacists and technician schools teach compounding as part of their curriculum, but most pharmacists and pharmacy technicians graduate with some basic required competencies to compound. Unless you are working at a specialty site, most pharmacy practitioners should not require additional training to fulfill the requirements laid out in the standards of practice. However, there are many compounding courses and educational resources available if a practitioner wants to expand their knowledge. Appendix C of the Standards of Practice lists topics that could be covered during training. This list is not all-encompassing, and not all topics listed are relevant for every pharmacy setting. The amount of training required depends on the compounds being prepared. Someone who is making a simple hydrocortisone 1% and clotrimidine cream likely needs less training than someone making a complicated pain cream with multiple ingredients. The amount of training a staff member requires also depends on their role in the compounding process. Some training topics that I feel should be covered in most community pharmacy settings include general compounding topics such as the policies and procedures, master formulation record development, how to assign beyond use dates, calculations, and how to measure accurately. I also think there should be some training regarding hazardous medication, such as how to identify a hazardous ingredient, when and how to use personal protective equipment to limit exposure, how to handle hazardous medication, and emergency measures in case of exposure. Last but not least, I think cleaning topics are important, such as the policies and procedures around cleaning the compounding area equipment, and facilities. I want to share a compounding error that occurred recently in New Brunswick that highlights the importance of supervision, independent double checks, and knowing your responsibility when it comes to compounding. A 3-year-old child was prescribed clonidine 0.025 milligrams once daily in the form of compounded gummies. The child ended up receiving gummies that contained 25 milligrams of clonidine rather than the 0.025 milligrams prescribed. The child was rushed to hospital by ambulance with signs and symptoms consistent with clonidine toxicity. Thankfully, the parents had trouble getting the child to consume the entire gummy, so the child only ingested a portion of it. If the child had consumed the entire gummy, the dose likely would have been fatal. Upon investigation of the error, it was discovered that the gummies were prepared in the designated compounding area with no pharmacist supervision. The pharmacist was not involved in the compounding process until the final check, which was completed after the compound was made, but before it was dispensed. The pharmacy had never prepared this particular compound before, so an employee developed and entered a formula into the pharmacy system, but did so incorrectly, and inputted that 0.75 grams of clonidine was required to make 30 gummies instead of the correct 0.75 milligrams. This is 1,000 times more clonidine than required. The employee who made this error had training and experience compounding. The pharmacist who reviewed the formula, calculations, and final product was the pharmacy manager and the designated compounding supervisor. They reviewed the calculations in the dispensary rather than the compounding area. They were tired, hungry, and interrupted multiple times. I think we can all relate to this scenario. The pharmacist did not catch the error. Factors that contributed to this error include no written protocols or procedures, no documentation of calculations on paper records, no verification of formula, calculations, ingredients, or quantities by a pharmacist or registered technician before the compound was mixed. There was no pharmacist involvement until the gummies were made and ready to be dispensed. And of course, interruptions. This error could have been prevented if the pharmacist verified the formula and calculations in a quiet area free of distractions. The pharmacist should have also verified ingredients and quantities before the preparation was made. Regardless if the dispensing pharmacist was the compounding supervisor or not, they were responsible for overseeing the compounding process and verifying standards are followed during their shift. I think this is a good place to end Module 2, and I hope that you all have a better understanding of when to apply the standards of practice, how to determine if a compound is appropriate to make, and the different roles and responsibilities in the pharmacy when it comes to compounding. None of us want to get a phone call that we've made an error that affected a patient's health and safety.